I am going to talk about the diagnosis of melanoma, and that's an important question, but while answering that, I think it's important that we answer several other questions. So, what is melanoma? Are all melanomas the same? And then, with regard to the diagnosis, where do you even look? Where do you start looking for it? How do you look for it? What tools are available for you to help look for it? What do you look for? And then how do you know when you found it? So that will be what we'll attempt to answer here. So first, what is melanoma? Well, at the very most basic level, it's a malignant tumor, and you can read cancer there, that's derived from melanocytes. And those are the cells that produce pigment in the skin. And interestingly, they're also present in several other areas. They make the pigment in your hair, on your entire body surface area, including your scalp. They're also present on mucosal surfaces, and we don't usually think of that. So they're present on your lip, they're present inside your mouth. The melanocytes are even in the genitorectal mucosa, and even on the surface of your eye, and even inside your eye. Interestingly, melanoma itself may rarely even show up where melanocytes are not normally present. And that's by far the exception, not the rule, but it can be found primarily in the bowel, in sinuses, in the central nervous system. And we won't discuss that in detail. Most of what we'll talk about is skin surface melanoma today, which is by far the most common cases of melanoma. So melanoma is the most common cancer for young adults aged 25 to 29. And in fact, in the United States, it's the 5th most common cancer in men and 7th most common in women. So the prevalence of it, how many cases there are, is really quite high. And in an attempt to identify what a particular individual's risk is over their lifetime, about 1 in 50 people in the United States will have melanoma at some time in their life. Thank you. So the next question is, are all melanomas the same? And on the left, you'll see a gentleman named Bernard Ackerman, and he was the original proponent of the idea that melanoma is melanoma. Regardless of where it is, it behaves the same. If you find it later, it behaves worse. If you find it earlier, it behaves better. On the right is one of his proteges, Dr. Phil LeBois, who's in San Francisco. And he was a proponent of the idea that each melanoma is unique. And it was, in fact, one of his life missions to prove Dr. Ackerman wrong. And he's quite successfully done that, such that we now know, through a variety of different ways, that melanoma is unique based on where it comes from, and even in a particular area, one individual melanoma may be different from another. And we've identified that there are a variety of different mutations or genetic malfunctions that can cause a melanoma. And those mutations, they vary quite significantly based on the type of melanoma and where it's found in an individual and at what time in life it's found. Most of the mutations can be linked to sun exposure. And this is something that is very, very commonly known, that intense sun exposure can predispose you or increase your risk for melanoma. And the other interesting point is that some of the mutations are not related to sun exposure. They're considered sporadic or by chance alone. And if you think about this, it does make sense. Occasionally we find melanoma in very young children or in areas where you don't get much sun. So a melanoma that happens inside the mouth, not many people get much sun in the mouth. So by far, the great majority of melanomas have sun-induced mutations, but there are some that do not. It has been shown that indoor tanning will increase an individual's risk of melanoma by about 20% over their lifetime. So that goes to show that sun exposure does indeed increase risk and is potentially causative of mutations. In fact, in people that have more than 5 sunburns over their life, their risk of melanoma increases by about 80%, so a pretty big number. The particular abbreviations here are not important, but this shows that in a variety of different types of melanoma, the one on the far left is non-chronically sun-damaged skin. By far the most common mutation is in a gene called BRAF, for which we've identified a particular mutation, and now several treatments are available to target that mutation. But that is very different from the chronically sun-damaged skin melanomas, where they have a very different set of mutations. And then acral means distant, or in a patient it's on the palms or soles of the feet. Acral melanomas have a completely different set of mutations. And then mucosal are separate as well. So indeed, each melanoma is unique. In 2009, the first melanoma genome was sequenced, and this has given us lots of information about things that can go wrong with a particular cancer type. Since then, many more melanomas have been sequenced, and we're learning lessons seemingly every day about different things that can go wrong, and that gives us a chance to address how can we potentially target that as a treatment. And this is just a graph demonstrating each chromosome within the melanoma that was sequenced and the different problems, areas that have mutations or deletions of genetic material. So the next question is, where does it come from? And that is also important to know that a particular patient, or the host factor, the person-to-person differences, play a significant role. We talked about how sun exposure can increase your risk, but some people have mutations from the day that they're born that may increase their risk. And those are pretty uncommon. They make up only a small number of patients that have melanoma, but if they're there, we need to be much more careful with those particular individuals. Some examples are a somewhat common one, this MC1R mutation that's responsible for red hair. And those patients have lots of freckles, light skin, and a slightly increased risk of melanoma. A less common mutation is the CDKN2A, and that increases one's risk of melanoma by a lot. In fact, those patients also have risks of other types of skin cancer. And this would be a situation where multiple family members would have melanoma or a variety of different cancers. That's when we'd start thinking about looking for that, and really to help identify risk within a family. There are a variety of other mutations that have been identified, including this CDK4 and BAP1, that may be linked to a variety of other types of cancers, but by far these are in the minority. Most of the melanomas that we see have either sun-induced mutations or are that sporadic group, or just by chance. The different types of melanoma may present at different times in one's life. By far the most common is the superficial spreading melanoma. We'll look at some pictures to give you an idea of what this looks like, but it accounts for the great majority of melanomas and tends to present a little bit earlier in life, closer to the 50s. Nodular melanoma is less common, but it is actually more dangerous and presents around the same time of life. Lentigo maligna melanoma tends to occur on sun-damaged skin. It doesn't tend to run in families as commonly, and it tends to present much later in life and only accounts for about 10% of melanomas. And then there are a variety of other types, including the acral, or the melanoma on hands and feet, that tends to be in different populations. people that don't have as light skin. This is usually people that have a Hispanic heritage or have black skin. And there are a variety of other types of melanoma, including melanoma of the eye, melanoma of mucosal surfaces, and a funny type called clear cell sarcoma that has nothing to do with sun because it happens down close to your muscles. So now that we've talked about what melanoma is and what may cause for it, where do you look for it? Where do you even start? A variety of studies have tried to answer just this question. And in a pilot program in Germany, they took a region within Germany and screened everybody over a period of a year, more than 300,000 people. And after that 1 year of screening, there was a nearly 50% reduction in melanoma mortality over the next decade. So they showed that their efforts were helpful, but that would be very difficult, for example, in the United States, where we have more than 200 million people. So perhaps it would be more helpful to identify certain risk factors and look more closely at those groups. And a study attempted to do just that. What they did is they took people that had melanoma and they looked to see if they had been screened the year before. And those people that were screened had much better outcomes. They were twice as likely to have a thin or earlier melanoma than patients that weren't screened. So that tells us that identifying patients that are at risk and screening that population may help us to find melanoma earlier and have better outcomes long term. And that leads us to the next question. What does risk mean? Well, for melanoma, high risk can be identified by a variety of factors. Do patients have more than 50 moles? Do you have one or more atypical or dysplastic mole? Have you had melanoma in a first-degree relative? Does your skin burn easily? Do you have lots of freckles? And then do you have naturally red or very blonde hair? And that would identify that subset with the MC1R mutation we discussed. And then to define that, or to bring it down even further, what does very high risk mean? Who should we be watching very closely? People with more than 100 moles, with people with more than 5 atypical moles, people with lots of melanoma in the family, people that have had skin cancer or an organ transplant, or if they've been treated with ultraviolet therapy for a variety of skin conditions, or if they've had radiation in childhood. All of those people would be considered very high risk for melanoma and should be watched very closely. This is an example of somebody that would fit into the very high risk category, a patient with lots of moles, some of which have more than 2 colors or are large and asymmetric, and this patient looks like he's had a melanoma excision or a mole excision in the past. This would be someone we need to watch closely. So then the next question is, how do we look? What are we looking for and how do we find it? Well, you can use the naked eye, and if you do, some common criteria would be to look for the A, B, C, D, E's. A means asymmetry, so looking at this mole, which is most likely a melanoma, it's clearly different on one side than another. It's different in its shape, and it's different in its color. The borders, instead of being nice and round, have notches, and it's kind of growing off to one side. It has more than 2 different colors, so there's red, brown, black, dark brown. The diameter, in this case, is probably larger than a pencil eraser. That's the cutoff we use. And then E is for evolution. Is it changing? Another tool that's available to clinicians is to use a dermatoscope. And this is a device that magnifies the lesion and also uses polarized light to change how it looks and allow us to look closer. On the top is an example of a magnified lesion without polarized light, and on the bottom the same lesion with polarized light. It allows us to see the pigment much more closely and in much more detail. A newer device on the market is called the MelaFind Device, and this is a computerized device that evaluates a variety of different colors and spectrums to look at one particular mole, and then the computer compares that to known melanomas and decides, is this a high-risk lesion or a low-risk lesion? And it has been shown to be very sensitive to find melanoma, but there are also a number of false positives that it identifies, similar to a clinician. So that is a difficulty and a challenge that we're still trying to overcome. It is important to know that many, if not most, melanomas will arise on otherwise normal skin. So they don't all come from a mole. Even though some do arise within an existing mole, it's important that if you're looking at your own skin, you look over all of it, not just the areas where you have moles. Let's look at a few examples here. This is a lesion that has asymmetry of color and shape. There's clearly a darker area here, and there is an abnormality of the border where there's a notch. So this would be a suspicious lesion, but turned out this was not a melanoma. This was an atypical mole. Here's another example. This is on the leg of a child, and there are multiple brown spots, some with funny borders, some with multiple colors. This was not a melanoma. This was just a birthmark. Here's another example. Multiple colors, asymmetry of shape and color, and lots of little dots. So this would be concerning, but this is another example of a birthmark. Here's an example of a lesion that has very asymmetric shape and color, has multiple colors, white, pink, dark brown, black. This is an example of a superficial spreading melanoma. Here's a dark lesion on the forehead of a middle-aged gentleman with lots of little dark dots around it. It doesn't have multiple colors, but the shape is asymmetric and there's funny borders, and this was a melanoma. This is an asymmetric lesion on the chin of an older woman with multiple different colors from light brown to darker black and irregular borders. This is an example of the chronically sun-damaged skin melanoma. So I think, lastly, this lesion here is smooth color, smooth borders, and very symmetric. But this is an example of a melanoma that doesn't have pigment. I think this illustrates some of the difficulty in diagnosing melanoma. And it also illustrates that change, this lesion was new, can be a helpful clue for you to be concerned about a particular lesion. So once we find a lesion that we're concerned with, how do you make the final diagnosis of melanoma? Well, first you remove the lesion, or a clinician removes it, by a variety of methods. None are necessarily better than the other, as long as an appropriate portion of the lesion is removed, and then it's sent to the laboratory for evaluation. That tissue is placed onto a slide, and the slide is viewed by a pathologist under the microscope. This is an example of what a melanoma looks like under the microscope. There are many melanocytes that are abutted up to the epidermis. Some of them are bigger and darker than the cells surrounding it. And this is an example of a superficial spreading melanoma under the microscope. Unfortunately, there is some subjectivity to interpretation of these things. Even though we'd love to say that it is 100% objective, everybody will always come to the right and the correct diagnosis. It's not always the case. Some of the lesions can be challenging looking at them on the skin and looking at them under the microscope. So in an attempt to clarify that, a variety of different techniques have been developed to aid in the detection and the correct diagnosis of melanoma. One of those is called FISH, or fluorescent in situ hybridization. And this looks for changes in a particular chromosome within a cell. This example shows multicolored markers that are normal, but if those markers are broken apart and distinct from each other, it shows an abnormality. Another tool that's available is called comparative genomic hybridization, and this looks for different changes within a particular chromosome? Is there more material or less? And then lastly, a new tool that's been developed looks at different expression of genes within a melanoma or within a lesion of concern. And this illustrates that within each of these tests, let's see if I can find my arrow here, there are many lesions that a particular test will decide may represent melanoma, but some don't fit. And there are always a variety of lesions that are of question. So the gold standard in our quest for a gold standard will be able to detect every single melanoma without question. And we're not there yet, but we're getting there. So in summary, I think we've answered, or we've attempted to answer, what is melanoma? Are all melanomas the same? No. Where do you look for it? You look on the skin, but you look more carefully at patients with increased risk factors. There are a variety of different ways to look for it. When you're looking for it, you can use the A, B, C, D, E criteria to help you. And the way that you know you've found it is to consult with a pathologist with expert in the diagnosis of melanoma. So I want to say thank you for allowing me to join you, and I'm open to answer any questions.